So canaloplasty, the first step would be to make sure you have a great view of the trabecular meshwork, as with most MIGS procedures, right? You want to make sure you have a great en face view. And then you want to start engaging the injector into the nasal TM. And once it intubates, you make sure you watch the blinking light traverse the 360 degrees of your canal, making sure it's in the right path. And once it comes back around, then you're going to start a retraction process and asking your assistant to inject 3 clicks per clock hour would be my preference for 360 degrees. And when it comes back around, you are done. So I used to be a GAT girl. I was very much a believer of the original GAT procedure, 360 canaloplasty goniotomy. But this new iTrack Advanced injector is so much easier to use. It's ergonomic, it's very easy to intubate. So I'm a quick convert, and I use it for my canaloplasty as my go-to now. The analogy I want to tell my patients in terms of explaining what I'm doing when I'm doing canaloplasty is that it kind of is like a Drano procedure. You're injecting a gel, so you are opening up strictures more further down the pipe beyond the surface level. So, and really that's the mechanism that leads to clinical success. And you can titrate the amount of visceral dilation at any point, so you can retract and then advance. And it makes mechanistic sense, right? So the more gel you can inject into the system, the greater anatomical success you can expect to see with the canal dilation, and again, reducing resistance that way, increasing outflow for greater eye pressure reduction. So the iTrack Global database has shown that, that this is with more than 400 eyes at 1 year out. With a baseline of 17 millimeters of mercury, we can get down to 13 to 14 and an average 1 eye medication reduction as well. And in my own clinical practice, I'm seeing that replicated. So that's my expectation, and that's a great response. Really, for me, I would offer it to anybody who has an open angle, who has either high eye pressure or has any types of open angle primary or secondary glaucoma. Even though maybe early on in the disease process, there might be more plasticity and a greater efficacy, but it's low-hanging fruit. You really want to maximize the natural drain function in anyone as much as possible. And when the indication is for standalone surgery, oftentimes it's to reduce eye pressure, minimize that glaucoma progression. And when the indication is cataract surgery, because patient has visually significant cataract, then it's for most of the time a drop reduction and for sort of lifestyle and for improvement in comfort. So the top 3, I would say the first is that you want to pick the correct patient. Obviously, everybody could be a good candidate, but if you are able to offer this early on in the disease process, there can be greater efficacy when there's still plasticity in the natural drain. And the second factor, I would say surgically, you want to make sure that the catheter maintains in the right space and stays in the right path. And the blinking light really kind of does that for you. So it's a no-brainer to just follow the blinking light, and you're in the right path. And the third, I would say, is just to minimize movements as much as possible, all movements during surgery, to minimize the complications. So that's that means you're stabilizing the whole setup, you're minimizing movement into the eye and the patient and your hand. And that can be achieved either by providing more anesthesia to the patient, local as well as IV, and maybe using a stabilizer for your gonial prism so you can have some control over the eye.